Howdy, y'all. I'm Dr. Jeff Jarvis. Let's cover the traumatic out-of-hospital cardiac arrest protocol review. Now, fortunately, traumatic arrest is substantially simpler than medical arrest. Why? Well, because they're two completely different beasts. Medical arrest are caused by many things, from cardiac dysrhythmias to electrolyte abnormalities, things like hyperkalemia to critical hypoxia to toxicology to infection to pulmonary embolism. It's a really lengthy differential. Now, in medical arrest, chest compressions can help maintain perfusion while we defibrillate the dysrhythmia, or we treat the hyperkalemia, or we oxygenate the hypoxia, those types of things. Now, traumatic arrest, on the other hand, are almost by definition surgical diseases that can be caused by airway obstruction or obstructive shock from a tension pneumothorax or a pericardial tamponade, or most commonly, massive blood loss. None of those things are helped by chest compressions or medications. Now think about it this way. If your patient's last red blood cell bloop, 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 just went out onto the ground, what exactly are compressions going to be circulating? There is nothing left to move around the body. Compressions aren't going to work. Likewise, compressions, they ain't going to fix a tension pneumothorax or a pericardial tamponade or critical hypoxia. So both the causes and treatments for medical and traumatic arrest are different. One thing is the same though. If we don't get ROSC on scene, there is very, very little chance of survival. So transport is almost always futile and for the most part should be avoided. Now, it isn't immediately obvious, however, whether an arrest is medical or trauma. Classic example of this is a driver of a car who had a medical arrest, lost control of the car, veered off the road and had a collision. Now, when in doubt, particularly when the level of trauma, that mechanism of injury, does not match the severity of the patient's condition, in those cases, assume that the etiology is medical and work it according to the medical protocol, meaning full bore, you do the defibrillation, all the things, including the CPR. Now, VFib is pretty rare in a traumatic arrest, but by all means, if you see it, shock it. Because it is so rare in traumatic arrest, outside of, say, maybe NFL football players with commotio cordis, you need to think long and hard about whether there is actually a medical arrest going on masquerading as trauma. And as always, like I said, if there's any doubt, treat it like a medical arrest. Now consider withholding resuscitation in case of obvious death. Take a look at the withholding resuscitation effort protocol for more information, but I do want to get a quick reminder. From a BLS termination level, so BLS clinicians are there are two things you have to withhold: obvious death and no vital signs. So let's go over that. Obvious death, things like rigor mortis or exposed brain matter, prolonged submersion. Take a look at the protocol again for temperatures, but those are the things we talk about with obvious death. The absence of vital signs means there is no pulse, there's no respiratory effort, and there's no pupillary response. So at the BLS level, withholding, signs of obvious death, and no vital signs, you'll notice there's no ECG monitoring it. When it comes to ALS clinicians who do have that ALS ECG interpretation, they can withhold even if there are no signs of obvious death. For those traumatic arrests who have no vital signs, that is, no pulse, respiration, pupillary response, and the ECG shows either a systole or a PEA with a rate less than 40. PEA or that Brady asystolic PEA. Withholding resuscitation, either at the BLS level or the ALS level, as a reminder, does not need online medical control. That is by protocol. You don't need a doc to not start resuscitation. You just need a doc if you start and then need to stop. All right, so that's when to withhold. Really important because unfortunately it's fairly common with traumatic arrest. Now, the other key concept here with traumatic arrest is that there is no minimum time that you have to work the arrest like there is with a medical arrest. With medical arrest, we have to give our interventions time to work. With traumatic arrest, we either fix the problem quickly or it's futile. Now, with that in mind, let's go over the interventions that we can use in traumatic arrest. For our basic clinicians, open the airway and assure that we have adequate ventilations. Now, you can either use a BVM or rapidly place a supraglottic. Your call, depending on the circumstances. So, open the airway, assure ventilation. If there is bleeding from an extremity, slap on a tourniquet. Go ahead, place multifunction pads in preparation for ALS to get there, and start CPR. Now, start CPR until an ALS provider shows up on scene and can do further interventions. Now, I want to be clear about the value of chest compressions in trauma. To put it bluntly, there's basically no value in them. And it can be bad. It can be bad because it can distract us from doing interventions that can help. Now, other than assuring ventilations and stopping bleeding, however, all the interventions we can do are ALS interventions. So it's reasonable to go ahead and start compressions until we have clinicians on scene who can perform those interventions. Now, why? Well, because trauma typically happens in public, and we have very well trained the public. There's a cat in here. Cat? Off. Why? Well, because trauma typically happens in public with, people. And what people have? People have cameras. They have their cell phones. And we have trained these people to expect that we're going to do compressions. Now, it turns out social media has also trained them to video everything. I mean, why would they want to stop and help when they can video and put it up on TikTok? We just don't want to deal with that. So rather than argue with people or try to convince them of the science behind this, or appear to be doing nothing, it is reasonable to do compressions until we can do those interventions. All right, so ALS clinicians now arrive. If there are adequate resources, you can continue compressions, but please do not allow them to interfere with those other interventions. Remember, this is different than medical arrest, where medications and airway management should not interfere with compressions. That's because the compressions are more beneficial than medications in medical arrest. But the opposite is true with traumatic arrest. Interventions are more beneficial than compressions. Speaking of compressions, an MCD, mechanical compression device, will only get in the way of ALS interventions, so it shouldn't be used unless for some reason you're transporting. Now, at the ALS level, interventions are aimed at addressing the HOT acronym, HOT. H is for hemorrhage control, O is for oxygen and ventilation, and T is for tension pneumothorax. So apply a pelvic binder if you suspect an open book pelvic fracture to help us better control hemorrhage. Assure oxygenation and ventilation is underway and is effective, meaning you have good end-tidal CO2. And that doesn't matter whether it's an OPA or BVM or a supraglottic. You just have to have a good waveform end-tidal CO2. What about intubation? So intubation in a traumatic arrest, it's indicated only if you can't achieve adequate ventilation with a BVM or a supraglottic. If you don't, there's no waveform after a good mask seal positioning, after a supraglottic, after intubation even, then you gotta do a surgical airway. We can't terminate an arrest without assuring that we have addressed one of those addressable conditions, meaning airway obstruction. Got to make sure we're ventilating the patient. So that's H, that's O. Let's hit the T if you suspect a tension pneumothorax. So why would you suspect it? There is trauma to the chest. Maybe you hear decreased breath sounds, but I doubt you're going to hear anything. Trauma to the chest. Maybe it's difficult bagging. go ahead and dart the chest. I would rather you dart the chest if there's any doubt about whether there is a tension pneumothorax. All right, so what else is there? Well, there's epinephrine. We talked about how unlikely chest compressions are to be beneficial. Epinephrine, even worse. There's just no benefit from epinephrine because epinephrine, it's not going to fix the no red blood cells. It's not going to fix the tension pneumothorax. It's not going to fix the occluded airway. All right. Next up, in most cases, do not move these patients in traumatic cardiac arrest to the ambulance unless you absolutely have to for scene safety or for some other rare thing. What's going to save these people is those interventions, and we got to get them done rapidly. If we get them done rapidly and there's no response, well, then it's a futile arrest. Getting them into the back of the ambulance doesn't help there, and neither does transport. So, like I said, once we have assured that we have addressed all of the potential reversible conditions, the airway obstruction, the hemorrhage cessation, the tension pneumothorax, no ROSC, further efforts or transport are futile. Our goal again is to address the addressable and then call for termination. Let's say you do get ROSC. It's likely to be quickly after you correct the cause of the arrest. This isn't something where you decompress the chest and 20 minutes later you get ROSC. You're going to get it back within a minute or so. Once you get ROSC back, the goal now becomes rapid transport, rapid and safe transport to an appropriate trauma facility while maintaining the airway and assuring adequate ventilations and oxygenation. Keep in mind, you got to be maintaining that waveform end-tidal CO2 and looking at your SpO2. Remember that if there was a tension pneumothorax and you darted it, you relieved it, you got ROSC back, that pneumothorax can recur. Your cannula can get cramped. If that happens, just decompress again. Now, if you get ROSC, 2 grams TXA, slow IV push for adults, not in peds. And to be clear, we don't give TXA intra-arrest. All right, well, that is pretty much it. To hit the high points again, consider there might be a medical cause for the arrest and consider withholding resuscitation for obvious death. Once you address the addressable, contact online medical control for consideration of termination. No minimum time. Just address the addressable. As always, if you have any questions, feel free to reach out to me. Thank you all for watching, and thank you for what you do for our community every day. Take care, y'all. You, me, we are not communicating. I need to hang a little recording, no cat sign. But then that wouldn't help. You don't read, do you? My cats don't read. They ignore the door. What am I going to do about this?